Okay, just to continue, this is more the medical management regarding hyperthyroidism. Um, there's a few drugs here that are listed that are used to kind of inhibit thyroid hormone production. Um, some of them have to be taken for up to 12 weeks, particularly the PTU, to be therapeutic. And you also want to make sure that you teach patients the signs and symptoms of hypothyroidism because of this decreased production by the medication holding it down, they may actually develop signs of hypothyroidism, and you want to make sure they're able to notify you with those if that should occur. Radioactive iodine therapy cannot be used in pregnant women for obvious reasons, but it also is a method that the medication itself destroys the thyroid cells that are causing the problem. It may take up to 6 weeks to take effect. They also get treated with meds for about 3 months of antithyroid meds and or a drug called propranolol. And these patients need follow-up lab work fairly frequently to monitor for thyroid, looking at the T3, the T4, and just seeing what kinds of things, how effective is this been at bringing their hyperthyroid under control. Other things that can be done, you can have a thyroidectomy if drug therapy is not working. A subtotal thyroidectomy means that they only remove 90% of the gland. A total one, if it's being done for cancer, they will have to be on lifelong replacement therapy. That's part of the reason for doing the subtotal. It does allow to have a little bit of the gland left to still produce some normal thyroid hormone. But the goal of therapy pre-op is to try to get them to normal thyroid levels as best you can. Teach the patient to support their neck post-op. Make them aware of body image changes, not only with the surgery in the throat and maybe some of the hoarseness or potential issues with their speech that can come from the surgery. But also, they've usually been a very high-strung, thin person, and sometimes, taking the thyroid out can make them be more, hypothyroid. So they may see themselves gaining weight and having a lot of issues that are not what they're accustomed to. You just want to make sure they're aware of those things. Thyroid cancer is one of the key things that causes hyperthyroidism. They see about 56,000 cases of this annually. Again, women get this more often than men. These are some of the risk factors: radiation exposure, family history of goiter. There are 4 different types pretty much of the thyroid cancer, but the weird thing is the symptoms are really no pain whatsoever, and they just may have a palpable nodule in and around the enlarged thyroid gland that they can kind of feel, and they may notice that they have the swelling in the throat area that lets you know there's a problem going on. But often, other than that, they don't have a lot of symptoms unless it's the hyperthyroid symptoms. This is just a thyroid scan, what they call a cold thyroid nodule. When they do the thyroid uptake exam or scan, it actually, the tissue that is healthy in the thyroid gland will readily take up the thyroid and will show these darkened areas. If there is a dead area where there's cancer growing, it will not take up the radioactive iodine, and so that's why they call it, it's a colder area on the scan that indicates that there is a nodule present. Post-op management, you're really looking for, after a thyroidectomy, really high risk for hemorrhage. 24 hours after the surgery, you want to keep their head elevated to limit edema. As we've talked about with anything in the throat area in the past, you can have, if there's swelling, edema, bleeding in that area. You can have compression of the trachea leading to respiratory distress. You want to keep a tracheostomy set at the bedside in case one has to emergently be placed. You would expect that to be a complication that might occur from this procedure and be kind of prepared for it. You also may see some laryngeal nerve damage where the patient has difficulty speaking as a complication. They also may have parathyroid damage because the parathyroid glands just sit adjacent on each side to the thyroid, and sometimes they may get damaged as well during surgery. And if you don't have parathyroid function, you may, or have high levels of parathyroid, you may have issues with calcium levels that can lead to tetany. And usually a patient who's had a thyroidectomy is going to have lifelong use of calcium and vitamin D as a supplement. Another thing that can come related to post-thyroidectomy is what's called thyroid storm or crisis. And this is a life-threatening emergency in terms of severe hypothyroidism. If you cut into the thyroid gland itself to remove it, you get an immediate release of thyroid hormone out into the area of the neck, and this can be taken up by the bloodstream, making a person who's already hyperthyroid even more so. You also see this kind of condition sometimes on somebody who has never really quite understood that they had hyperthyroidism and it's been undiagnosed. And if they have extreme stressors like trauma, infections, pregnancy, suddenly they may go into what they call a thyroid storm or crisis. The 4 key symptoms of this are hyperthermia, and what that means is they get, extremely febrile, they get tachycardic, they can go into heart failure and shock. So this is a serious situation. In the early phase of someone having thyroid storm, because it can be due to stressors or high stimulation, you want to be able to put them in a room that's dark and cool and very little stimulation as a first step if they should start to have a temperature elevation, and kind of watch them very closely. And sometimes that may be enough to settle the situation down. If they continue with high fever, you're going to probably work on getting them moved to ICU. They're going to need to coolant blanking, IV fluids. They'll probably end up on a ventilator. They're probably going to need beta blockers to kind of get their heart rate and rhythm under control. They may need replacement of electrolytes and glucose. They're going to also be put on these anti-thyroid drugs like PTU, and probably on antipyretics or things to control the fever. They do say that aspirin is not indicated because it interferes with T3 and T4, and so that's probably not the best choice. Another condition that causes inflammation of the thyroid gland is called thyroiditis. And there is a chronic disease of this called Hashimoto's disease. And you want to make sure that you look that up, because a lot of times it's inflammation to where it totally damages the thyroid altogether. They may have some hyperthyroid with thyroiditis in the beginning, but then they eventually progress to where it's diseased to the point where it's not functioning anymore, and they have hypothyroidism is usually the end result with Hashimoto's disease. Most of the time they try to treat this with non-surgical management and drug therapy. If they're hypothyroid, then they may be put on thyroid medication, or they may do surgical management as well. In terms of hypothyroidism, again, this is more common in women. It affects 4% of the population. Primary hypothyroidism is usually due to destruction of the thyroid tissue, just like we're talking about with thyroiditis. But you can also have secondary hypothyroidism because your pituitary gland is not working or your hypothalamus is not working, because both of those send signals eventually down to the thyroid to make more thyroid hormone. And if either one of those are not working properly, then you tend to see, low stimulation of the thyroid to produce thyroid hormone. Iodine deficiencies are the most common cause worldwide for people to have hypothyroidism. And again, here are some of the causes of hypothyroidism: Hashimoto's thyroiditis, TSH deficiency, meaning that your pituitary gland is not making enough thyroid stimulating hormone, iodine deficiencies, and then there are other medications such as amiodarone or lithium, if you're on those for long-term use, that can make a patient become more hypothyroid. These are just the typical lab results, again, looking at hypo and hyper thyroidism and kind of explaining how those work. If you have primary hypothyroidism, you're going to have a low production of thyroid hormone because something's wrong with the thyroid gland. But you may see that you have high levels of thyroid stimulating hormone because your pituitary gland recognizes that you need more thyroid hormone in your bloodstream and starts sending more stimulating hormone to try to get this damaged thyroid gland to work. For secondary hypothyroidism, you also are going to have low production of T4, but it's usually driven because there's low production of TSH by the pituitary gland, so it's just not getting the signal to continue to produce more thyroid hormone. So again, here are some of the manifestations of hypothyroidism, and it's sort of pretty much a reverse. You have a decrease in the thyroid hormone for whatever reason. They have a low metabolic rate. They may also develop a goiter. They have low heat production, so they're always cold all the time. They have fatigue, weakness, anemia. They gain weight. Their GI tract get slow. They may become constipated. They have, a lot of somnolence, sleepiness. They may be bradycardic. They may have hypotension, and they may be hypothermia and have very dry skin. So these are some of the things that you expect. For neuro, you're looking for a change in level of consciousness to be real drowsy, lethargic. They may have evidence of a goiter. Their cardiac output may be very low perfusion, low heart rate, low respiratory rate. They may have low blood pressure. Sometimes they'll have a fluid accumulation because they're not perfusing well, so you see a lot of edema. They may have anemia because they've got a lot of fluid that they're retaining. You can treat the hypothermia to try to increase their metabolic rate is the key thing you want to do, because the treatment for these folks, as you can imagine, is primarily they've got to have some thyroid hormone given to them. And some of just treating with the thyroid medications to replace the thyroid hormone is kind of get them balanced back to the right standpoint. So this is morbid Matilda. Everything is slow. She's just really overweight, obese, looks to be a little edematous, and that's typical what you see. Drug therapy for hypothyroidism is lifelong replacement therapy. You see levothyroxine. Synthroid is the other name for that, and that is used to increase the levels of thyroid hormone. You do a lot of patient teaching with them. You need to take this medicine an hour before or 2 hours after your meals in the morning. You need to hold it if your heart rate's elevated. You need to monitor for coronary insufficiency, and you often have to titrate the dosage to the patient to get it right. And you also need to watch out for its effect on increased effect on